For this first mood disorders video, our focus will be on antidepressants, which, keep in mind, do have indications beyond major depressive disorder or depression, which I will call it moving forward. But in this video, we're going to specifically focus on their antidepressant effects. So before we can talk about imbalances that lead to depression, we first need to talk about mood regulation and the two primary neurotransmitters thought to be involved, and a third to a lesser degree, which is based on what's called the monoamine hypothesis. Because, like our dopamine hypothesis in schizophrenia, this is the predominant theory behind why depression results and what many of our therapeutic mechanism of actions are based on. So the two main neurotransmitters thought to be involved in mood regulation that are targeted by most of our antidepressants are serotonin and norepinephrine, which will be our main focus, and dopamine, which we will just mention because it is not a primary target for most of the drugs we're going to talk about today. But together, these three neurotransmitters work together to regulate mood, emotion, behaviors, cognition, among other functions. So we've already gone over neurotransmitter release in quite depth in other videos, so let's just do a refresher of the key points in the signaling cascade. So serotonin and norepinephrine release can bind different receptor subtypes on the postsynaptic side to propagate signals, or on our presynaptic sites to lead to feedback inhibition and turn off neurotransmitter release when no longer needed. And this can be through presynaptic autoreceptors, so for example, norepinephrine acting on adrenergic neurons to turn off norepinephrine release, or on heteroreceptors, so norepinephrine acting upon our alpha-2 receptors on serotonergic neurons to turn off serotonin release. Also, remember, we have our reuptake transporters for each neurotransmitter, even dopamine not shown, to recycle our neurotransmitters when no longer needed, or feed these neurotransmitters to our mitochondrial monoamine oxidase, or MAO enzymes, for degradation. And remember, MAO-A mostly handles norepinephrine, serotonin, and tyramine, and MAO-B is more for dopamine, if you remember from the Parkinson's disease video. So again, these are all of our normal signaling components that lead to appropriate mood regulation. So what happens in the signaling cascade that leads to depression? Well, our monoamine hypothesis, which is the leading theory behind depression and the basis for our antidepressants, is that there is a deficiency in these monoamine neurotransmitters. So without sufficient serotonin and norepinephrine, plus or minus dopamine not shown, we cannot have appropriate mood regulation, leading to depression, as well as a number of other symptoms commonly observed with depression, like impaired cognition, poor memory and attention, avolition, anhedonia, etc. And as you can imagine, this deficit can lead to receptor upregulation and secondary messenger changes that try to compensate, but this is unsuccessful, and we'll come back to this in a future slide. So if the body is unable to compensate for the monoamine signaling deficiency or dysregulation, how can we restore neurotransmitter signaling levels to, over time, reach appropriate receptor levels and more balanced signaling? So moving to our next slide. So there are many antidepressant options to choose from that help restore balance to the deficient monoamine signaling cascade. And a number of these classes we have already discussed in different contexts, but their mechanism of actions are going to remain the same for their antidepressant effects. So we'll start out with some of the more historical agents that might be seen from time to time, but are the reason some of the relatively newer classes of agents have been developed. The first up are going to be the monoamine oxidase inhibitors, or the MAOIs. And these can be either selective or non-selective for MAO-A or MAO-B enzymes. And these will inhibit the degradation of their respective monoamines, leading to increased neurotransmitter bioavailability in the neurons to be released into the synapse. So more serotonin and norepinephrine released, for instance, means more receptor stimulation, which addresses the deficiency in the short term. And over time, this receptor stimulation will return receptor levels and coupling back to more normal levels. So there is more appropriate mood regulation and a relief of depressive symptoms. Now, the reason these have much been replaced by newer agents, except in refractory or atypical depression, is because of the high levels of monoamines that result, increases the risk of hypertensive crisis, as well as that serotonin syndrome and the tyramine reaction and a countless number of drug-drug interactions that increases these risks. This is one of the big culprit drug classes for drug-drug interactions, and though you may not see these much, you will hear them often in commercials or when reviewing interaction checkers. Our next class of agents we discussed in depth for the peripheral neuropathy video, and these are the tricyclic antidepressants, or the TCAs. And these are going to include agents like amitriptyline, which, remember, will inhibit the reuptake transporters for both serotonin and norepinephrine. So will again increase neurotransmitter levels short term, and then long term lead to receptor regulation, promoting more appropriate signaling and mood. Now remember, these are very dirty drugs in that they have a lot of off-target effects that explain their side effect profile, in addition to the usual side effects you would expect from increased serotonin and norepinephrine levels. And for these reasons, in most situations, these are avoided with a preference for the newer agents to be used. Now on to our newer agents, and we will start off with our selective serotonin reuptake inhibitors, or our SSRIs. And these are a first-line option and include things like sertraline, fluoxetine, citalopram, and others. And these agents will more specifically inhibit the serotonin reuptake transporter. So in the short term, it will increase serotonin levels in the synapse to correct that deficiency. And over time, will stimulate those serotonin receptors, which in the long term will correct any receptor regulatory imbalances. It is thought that the main benefit is actually the downregulation and desensitization of the off-switch receptors on the presynaptic side, which likely were upregulated with the deficiency. Also, remember there are different subtypes of serotonin receptors on the postsynaptic side. Some, like the 5-HT1 receptor subtypes, when they are stimulated, are thought to lead to antidepressant effects. Some lead to depressive effects, like the 5-HT2 and 3 receptor subtypes. And stimulation of these receptors is also responsible for promoting anxiety, sexual dysfunction, as well as GI distress, which we will revisit ADRs in just a second. But keeping in mind these antidepressant and depressant serotonin receptor subtypes, SSRI treatment will also lead to downregulation of those receptors that promote depression, like HT2 and 3 subtypes. So many of the SSRIs and the agents we talk about today may alter the regulation of those antidepressant serotonin receptor subtypes over time, but a lot of them will have some agonistic activity at these HT1 receptors, which is a bonus. So the SSRI short-term and long-term help correct the deficiency and the imbalanced receptor regulation, respectively. Now, keep this general reuptake inhibitor mechanism of action in mind because it applies to the TCAs as well as any other agent with this transport inhibition. Now on to the SNRIs, or the serotonin norepinephrine reuptake inhibitors, like venlafaxine that we talked about in the diabetic peripheral neuropathy video as well. And their mechanism of action remains the same and similar to the SSRIs above, but now also adding in this norepinephrine reuptake inhibition. So we end up with more norepinephrine over time, mostly leading to that downregulation and desensitization of those off-switch presynaptic receptors, promoting both serotonin and norepinephrine release, as well as some of those same postsynaptic changes, returning monoamine signaling to more appropriate levels. Now we are going to move into our atypical antidepressants, which is a catch-all for the remaining agents we are going to discuss today. And these will include trazodone, vilazodone, and or tioxetine, for example, and these will all still inhibit serotonin reuptake transporters and lead to a similar downstream short and long-term effects. But these agents also have different modulatory or stimulatory effects on different receptor subtypes. For example, trazodone has antagonistic activity at those depressive serotonin 2 receptor subtypes, as well as the alpha 2 receptors. Vilazodone, on the other hand, has partial agonistic activity at the 5-HT1 receptor subtypes, which are the antidepressant ones. And vortioxetine has agonistic effects at these antidepressant receptors as well, and antagonistic effects at the serotonin receptors like our HT3 subtype that are depressive. So these additional effects are thought to help relieve some of the side effects associated with that receptor desensitization and downregulation phase from that surge of serotonin non-specifically hitting both the antidepressant and depressant serotonin receptors. And we will revisit the ADR profile again. Now, our next agent that's an atypical antidepressant shares a similarity with trazodone, and it is mirtazapine, which actually does not inhibit reuptake transporters at all, but inhibits alpha 2 receptors, which, remember, are our off switches for serotonin and norepinephrine. So by blocking the ability of norepinephrine to stimulate these alpha 2 receptors, we lose that off switch and promote serotonin and norepinephrine release to address that deficiency and help regulate appropriate receptor occupancy, at least on the postsynaptic side. And it also antagonizes the depressive serotonin 2 receptor subtypes, and this will shunt that serotonin that's being released to the HT1 receptors to get those antidepressant effects. Now, our last atypical agent is bupropion, which is thought to lead to antidepressant effects by inhibiting the reuptake of norepinephrine and dopamine. So we get that increase in the synapse and downstream long-term receptor regulation again, but this time altering norepinephrine and dopamine signaling. Moving to our next slide. These are all of the antidepressant classes and mechanisms of action that we will discuss in this video, and these MOAs may seem more complicated, but a good way to think about this is by thinking about what will be helpful in the short term with initial therapy. So for instance, combining a serotonin reuptake inhibition action with serotonin 2 receptor subtype antagonism makes sense to minimize the potential worsening of depressive symptoms and side effects with initial treatment from serotonin hitting all of the receptors, versus the long term, where the antagonistic activity may actually make it more difficult to achieve appropriate receptor desensitization and downregulation. So this is just an example, but may help you understand these MOAs a bit better. And this may also help serve as a reminder as to why these agents must be started low and titrated up, and that they cannot be abruptly discontinued without a taper. So we have mechanism of action, and now let's discuss ADR profiles a bit more in depth and how these can be leveraged to, again, pick the best drug for your patient or add agents to initial therapy if combination therapy is needed in a way that promotes adherence. And this should be a little bit more straightforward compared to our antipsychotics or our anti-epileptic drugs. So moving to the next slide. So this schematic should look familiar, and we know that HT1 receptor agonism, either via drugs directly or indirectly through serotonin, generally improves depression. But agonism indirectly or directly at the serotonin 2 and 3 receptor subtypes is actually thought to lead to those depressive effects, the sexual dysfunction, anxiety, insomnia, anorexia, and GI distress. So antagonism at these receptor subtypes will lead to antidepressant effects. Same with antagonism at our alpha 2 receptors, which are on those postsynaptic terminals that would usually serve as the serotonin and or norepinephrine off switch. So if we block those, we get more serotonin, we get more norepinephrine, and we get antidepressant effects. Now, I'm simplifying this to some degree, but the key point is there are receptors that counteract each other, so just keep that in mind. Now, just like those antipsychotics and the antidepressants can also have off-target effects at various receptors, like our alpha-1 receptors, our H1 histamine 1 receptors, and our muscarinic receptors to influence their side effect profile. That may include orthostatic hypotension, sedation and weight gain, and anticholinergic effects, respectively. So moving on to our next slide. So similar to other videos, this chart can help you understand the MOAs and side effect profiles and how these can be leveraged to promote adherence and select the best drug or drugs for your patient. So you can go through this chart, think about these targets, and think about different patients you may come across that come in with depressive symptoms and what questions you can ask to help guide your selection of agent. So, for example, an elderly patient comes in that has a low blood pressure at baseline and has fallen in the past. Which agents would you use? Which agents would you avoid? What about a patient that has only partial resolution of depressive symptoms, comes in with complaints of insomnia or excessive daytime sedation, or could use appetite stimulation? So think about these questions using this chart. And now let's get into some specific considerations you should be aware of for each of these. Now, one thing that will be applicable to a good number of agents on this slide is that many will be metabolized by CYP enzymes, specifically CYP2D6, which remember has a lot of pharmacogenomic considerations to be aware of, as well as drug-drug interactions. There's also going to be a black box warning for all of these agents for suicidal ideation, and behaviors, because there's going to be an initial increase in serotonin with most of these agents, and this can increase motivation to act on these suicidal thoughts. And as I said earlier, this surge of serotonin can actually worsen depressive symptoms initially, so making sure patients are counseled to report any worsening of symptoms or any of these thoughts is important. And with all of these agents, there can be a risk of withdrawal if the agent is abruptly discontinued, and this is very uncomfortable, so adherence is going to be key, and tapering off the drug will be needed if for whatever reason the patient does need to stop the medication. So moving to our first group of agents, which is our SSRIs, and their mechanism is going to lead to this increased level of serotonin, which is going to agonize all of our serotonin receptors, even our serotonin 2 and 3 receptor subtypes, which are the ones that can cause sexual dysfunction, anxiety, and GI distress. Beyond these ADRs, it's going to vary some within the class. For instance, paroxetine is the most sedating and anticholinergic and has the most weight gain associated with it, while fluoxetine is more likely to cause insomnia and anorexia. And Celexa, for example, has the highest risk of QT prolongation. So just keep in mind that there are going to be some differences among the agents within this class. Next are SNRIs, which are going to have a very similar side effect profile as our SSRIs, but now with a bit less risk for sexual dysfunction concerns and more adrenergic effects, like increases in heart rate, blood pressure, and insomnia. Now, we have already discussed the TCAs and why they are generally not a first choice, but sometimes when combination therapy is needed and there is insomnia reported, these can be sedating and taken at night to help, but there are other options that will have a similar effect. So these will also have similar serotonin and norepinephrine concerns as our SSRIs and our SNRIs. Next, we're going to jump down to trazodone and mirtazapine, which are also sedating adjuncts. That can also be added on when patients have complaints of insomnia. So trazodone comes with more of a risk for orthostatic hypotension compared to many of the other agents on the slide. And then mirtazapine actually comes with more metabolic changes and weight gain, which you would expect based upon their receptor binding profiles. Now, vilazodone and vortioxetine are relatively newer, so they're going to have a shorter list of side effects, which makes sense based on their chart as well. And those listed will be somewhat similar to the other groups of agents, but now just more expensive. And then lastly, bupropion, which is going to be the most stimulating of the agents. and can be used as an add-on for those experiencing excessive sedation throughout the day that need combination therapy, for example. So because this is going to be more specific for norepinephrine and dopamine targeting, this agent is going to have our lowest risk of sexual dysfunction. But this agent does come with a risk of seizure and should not be used in those that have a predisposition. There's also going to be a risk of insomnia, weight loss, agitation, nightmares, and because we are messing with dopamine, we can have behavioral changes and even mania is possible. So moving to our last slide. So now between the summary slide and the last slide outlining the ADR nuances, you are hopefully better equipped to appreciate the complexity of the antidepressant class, which I hope you now recognize that this is sort of a trend amongst all of our CNS active agents. And by having medications in each drug class that vary slightly in mechanism of action and ADR profile, this opens the door for more in-depth conversations with patients to identify which therapeutic regimen they are most likely to adhere to. And if a patient comes in with a side effect concern that may impact adherence, you have all of these options that vary slightly to help you problem solve for your patient and improve patient outcomes. Now, one important thing to consider is that patients may be using St. John's wort, which is a natural supplement patients may think is a safe, natural option for helping with depression. So it will be key to ask about supplements in patients with depressive symptoms because if gone unchecked, this can increase the risk of serotonin syndrome when combined with some of these other antidepressants and is an inducer of CYP enzymes. So a slew of drug-drug interactions. So keep this in mind as you're having these conversations to pick the best regimen for your patient because you need to be aware of what natural supplements they are on before adding new agents